Welcome to this special edition of Diabetes Core Update, focused on reduction of residual risk in cardiovascular disease with a focus on triglycerides. I'm your host, Dr. Neil Skolnik, professor of family and community medicine at the Sidney Kimmel Medical College of Thomas Jefferson University. This special edition is sponsored by Amarin and was originally published in August 2023 and is now being republished based on popular demand. Joining me for this series is Dr. Christie Ballantyne. Dr. Ballantyne is a professor of medicine, cardiology, and director of the Center for Cardiometabolic Disease Prevention, Baylor College of Medicine. Welcome, Christie.
Thanks, Neil.
Christie, we're going to have two podcasts focused on residual risk reduction. In this first podcast, we're going to discuss the concept of residual risk, as well as how and when to address it. Then in the second part of this series, which will be a month or two from now, we'll be discussing some common clinical cases and real-world challenges with regard to residual risk reduction. But let's start with the basics. For over 30 years, statins have been the cornerstone of lipid management to reduce the risk of vascular disease. Can you talk a little bit about the concept of residual risk?
So, you point out statins have been a tremendous advance. These medications which lower LDL cholesterol work in a very wide variety of patients. However, they reduce the risk. They don't abolish the risk of cardiovascular events. So we also know that, in the trials that have been done, you may see a risk reduction of 25 to 35 or 40%. But that means you're still having, somewhere between 75 and 60% of those events are happening that, were the same in the placebo group. So it's a big advance. And it's always the challenge of when you're having a patient in front of you and they're worried about, basically, they don't want to have an atherosclerotic event. They don't want to have an MI or a stroke. So what is it that you can do to optimize risk reduction? And so even if you see someone who's been put on a statin, it doesn't mean that you've necessarily gotten rid of all of their problems in terms of cardiovascular disease.
Yeah, and it's so important. There's a lot of ways that we approach cardiovascular risk reduction. We take care of blood pressure, we take care of diabetes, we try to get people to stop smoking, lose weight, eat a better diet. Can you explain the place of triglycerides in all of this?
So you point out that we know there's many factors that are important in the initiation and the progression of atherosclerotic cardiovascular disease. And so in addition to these focus on lifestyle, one of the things you want to look at is which patient is going to be at higher risk. Because there are some people that you come in and, they quit smoking, you treat their blood pressure, their lipids normalize, everything looks great. You've got these other patients where their triglycerides are still up. What does that mean in terms of their risk? Well, so we have two issues. One of them is a risk marker. Who are the patients that remain at a high residual risk after you've treated them with a statin? Well, we know that people with high triglycerides remain at risk. So it's a risk marker, and it's the same way for years we used HDL cholesterol as a way to identify people at a high risk. Now, the tricky part is, okay, risk marker or risk factor, and this has been an area where triglycerides and HDL cholesterol have been a lot more confusing than the LDL cholesterol story. The LDL cholesterol story, pretty straightforward. We know that if you have a high LDL, the risk goes up. You lower the LDL by more than one way of doing it, the risk goes down. And the genetics all line up very clearly with that. It hasn't been so straightforward when we get into things like HDL and triglycerides.
Yeah, I remember in 2011 with the AIM-HIGH trial, we all expected niacin, which lowers triglycerides and raises HDL, it was intuitively obvious that it would show a benefit on cardiovascular outcomes, but intuitively obvious isn't always true in real life, and it didn't do that in the trial, and it showed us that niacin was not benefiting patients. So it's one, I really like the term you used, risk marker. It's one thing, and it's the beginning of our knowledge to know that there's an association, but then the next step is the question of, does addressing it, does lowering it with medicines improve outcomes? Can you tell us a bit more about that story?
Well, you're exactly right. We had niacin was studied many, many years ago in the coronary drug project, and it actually did reduce events. But it turns out that niacin, it lowers cholesterol, lowers LDL cholesterol, it raises HDL, lowers triglycerides. And we knew HDL cholesterol was a big risk marker, and the triglycerides are a risk marker. It seemed obvious that after you use a statin, if they had a low HDL or high triglyceride, you would get added benefit. But it looks like, the statin had already lowered the LDL. And then when you added the niacin, we got nothing. I mean, it was very disappointing for us in the field. And there was another one that was done later on by the Oxford group, where they did a very big study, and they also saw that adding, this was a niacin laropiprant combination on top of a high intensity statin, did not give any event reduction. So, it turns out we've seen this with some other things like fibrates and things. So, and as you said, the modern era is you want to get people on statin. That's our starting point. So it's a different conversation for the patient who can't take any statin. But if someone's on a statin and they have a high triglyceride, we know that their risk is up, but it's been a little bit tricky as to how do I lower that risk.
So can you lead us through some of the evidence there? So we talked about niacin, also triglyceride lowering. There is fibric acids, there is regular old fish oil that you can get at Walmart, and there's icosapent ethyl, and they're all different. Can you talk a little bit about that?
So this has come up with we go back to the fibrate story. We had once again an old study, the Helsinki Heart Study, used gemfibrozil, and it worked, but that was prior to statins. And gemfibrozil, if you weren't taking a statin, it lowered cholesterol, it lowered LDL, raised HDL, lowered triglycerides. Unfortunately, then we had trials with fenofibrate, but when you added it on top of a statin, it looked like niacin again. For some reason, we didn't get that extra benefit with it. So it does turn out that we've done a lot of work over the years with omega-3 fatty acids, so those, it turns out, first of all, is in terms of the lipid effects, you're looking at when you see omega-3 fatty acids, and if you're buying a supplement, and those are not over-the-counter drugs, those are supplements which are kind of under health food regulations. You really need to look at what is the concentration of eicosapentaenoic acid and docosahexaenoic acid, so EPA and DHA. And we did some of the early studies that show that if you gave 4 grams a day of a combination of EPA, DHA, you would lower triglycerides. And that data, along with another center, led to the approval of an agent initially developed in Norway for triglyceride reductions with it. So, and this is now, it's a generic, but it was kind of prescription 3 omega-3 ethyl esters, which many people were familiar with. So that lowered triglycerides. Now, we didn't have an outcome study, but they did some low dose studies on top of statins that did not work for it. After being involved with this, a small company asked me, they said, well, we think EPA is different. And I'm like, well, I mean, it might be different. I don't, like you said, there's surprises sometimes
Right.
with it. And they said, why? And they said, well, we think it's different because we don't think it's going to raise LDL. We know that when you use the mixture together, LDL went up some. We think there's different biological properties. It turns out the omega-3 fatty acids, we think of lipids as, a lipid profile. You got triglycerides and cholesterol. But it turns out if you go to the biochemistry of lipids, and remember, I think the phospholipid bilayer, and so in a cell, and then basically all these signaling molecules are in that phospholipid bilayer, and then there's tremendous number of fatty acid molecules that are in fact related to inflammation. There's like the resolvins, and there's a different one. You have the E resolvins are derived from eicosapentaenoic acid. With it, D resolvins or docosahexaenoic acid. So there's a lot of very complicated biology that gets into leukotrienes and arachidonic acid that goes beyond looking at plasma triglyceride levels for it. So we did a study looking just in people with heart disease called the Anchor study. And yeah, it turns out that triglycerides went down, LDL went down a little bit, ApoB. And then there was a large outcome study called the Residency study. And this was done taking people on statins with the addition of EPA, 4 grams a day, and there was a reduction in cardiovascular events. So a large reduction in cardiovascular events, from 25% reduction in events with it, reduction in cardiovascular mortality, stroke, MI. So it was a very impressive result with that. And, we thought, well, here we go. We got the omega-3 fatty acids that got more complicated because I was also a member, I was involved with that study, and a member also of the strength trial. And we used a different one. It's omega-3 carboxylic acid, a mixture of EPA, DHA, slightly different form that was supposed to give a little better absorption. And once again, didn't work. So we didn't see the benefit. So yeah, I forgot to say, very important. The reason they were so excited about EPA is there had been a study in Japan called the JELIS trial.
Right.
So this was a study that was done what we call a PRO design, prospective, randomized, open label blinded endpoints. So it was a randomized trial. There's no placebo in that study. So it's just, people get randomized to something and they look at the events to a blinded adjudication committee. And that showed, even in Japan, where there's quite a bit of fish consumption, that the EPA had a reduction in cardiovascular events. So basically, the company was pursuing this because they felt they had some evidence that it was different. And, there was a reduction in events with it.
So we have at least 2 trials, the JELIS trial and then the larger randomized blinded style, the Residency trial, that both showed the same thing, basically a decrease in MACE, major adverse cardiac events, in the Residency trial by about 25% with EPA alone, icosapent ethyl alone. And then it's fascinating because the strength trial, which is a wonderfully carefully done trial of a particular fish oil, I think it's fair to say, that had enhanced absorption, but EPA and DHA didn't show anything. So it showed, I guess, icosapent ethyl. It supported the hypothesis that EPA alone has an effect that improves outcomes in people with high triglycerides still on a statin. Is that a correct interpretation?
So, and I think that is a correct interpretation. This went to the FDA to go over the basically for a new indication. It had been approved for reducing triglycerides for severe hypertriglyceridemia. And now the FDA, so one thing that should be mentioned is that the placebo was a mineral oil placebo. And mineral oil was chosen because it turns out it's a capsule. When you give the prescription omega-3, you have a capsule. And if that capsule had water, people could tell the difference. It's easy to see the difference between water and an oil. So they use a mineral oil because it's not absorbed. And now one of the possibilities raised is, well, maybe the mineral oil was doing something at first. So as you point out, the first study that was done, which was the hypothesis generating study, didn't have a placebo. It was the jealous trial. So there's no placebo. It couldn't possibly be that. Then the FDA looked at the issue of placebo, and looked at CRP and LDL changes, and they felt that, look, even if you were to say there was some kind of adverse effect or the placebo was doing something, it could only explain a small part. 25% is a large risk reduction. And so they looked carefully at this issue. Could there be something about the placebo? And they felt that the data really didn't support that. And as you know, it's in many guidelines in terms of the American College of Cardiology, European guidelines. The ACC just had a pathway for patients with chronic coronary disease. So now, one of the other things that makes it complicated is it doesn't appear to be simply the triglyceride reductions or the ApoB or LDL changes. Those are small changes, and it would not explain it. So we get into what is the actual molecular mechanism. And as I said, there's a lot of very complex biochemistry and biology of what the derivatives of EPA can do at the cellular level. So it's still an area, I think, that's kind of open for study and investigation to understand exactly, well, how exactly does this drug work?
I think often we have a hypothesis and then we see clinical trial results and we need to backfill what the real mechanism is. Certainly that's going on with SGLT2s and their effect on the heart.
Great example. I mean, I think sometimes you can see the clinical observation and you have some ideas as to the potential pathways, but nailing that down can take years and years of investigation. Would it take how long for figure out how digoxin worked? It took like 100 years, I think.
Yeah. Now, are there any adverse effects that prescribers need to be aware of with
so there is a slight increase in atrial fibrillation. Now, this is going to be more likely for someone who's had a prior experience of atrial fibrillation. So one important thing is that there was no increase in stroke. There was a reduction in stroke. But it is something, I think it's an interesting thing to a primary care audience in that, I have a lipid clinic, and I refer all the tough EP things to my colleagues who are EP. But you know what? One of the things that's come up now in terms of the issue of palpitations is, smartwatches.
Right.
Like an Apple Watch where, if there's a real concern, now a lot of times the patient can actually, if there was a history, of this, and it's a type of thing that patients can actually monitor themselves.
It's
pretty cool technology.
It's amazing. And the Apple Watch study back a few years ago in the New England Journal really showed it to be incredibly accurate. We're using that in primary care, and we're having not just us using it. Patients are coming in proactively and having us, address AFib that's been diagnosed. So it really is, in areas like where people have palpitations, helpful technology. But it is important for our audience to be aware of with this. Now, in primary care and endocrinology, and let me tell you, Christie, you weave a wonderful story. It is not easy to make science engaging, and you do. In our field, in primary care and endocrinology, we can't be experts on all the trials out there. So it's so wonderful, one, to hear about the evolution of knowledge in this area. And we often take our direction from guidelines. So just let's spend a couple of minutes going over that. I know that the 2023 American Diabetes Standards of Care are consistent with the evidence that you just went over. They state, and I'll quote here, individuals with atherosclerotic cardiovascular disease or other cardiovascular risk factors with diabetes on a statin with controlled LDL but elevated triglycerides, and they specify 135 to 499 milligrams per deciliter. The addition of icosapent ethyl can be considered to reduce cardiovascular risk. And in the ADA guidelines, that was given a grade A recommendation. Recently published, can you go over the 2023 American Heart Association, American College of Cardiology guideline for the management of patients with chronic coronary disease, and share with us what they had to say about residual risk and triglycerides, or any other guidelines that you think are relevant?
So they came straight from, there was a pathway by the ACC, an expert consensus pathway. Celine Ronnie was the first author, as a colleague of mine. I was a co-author on that. And they take you through the issue of, now we know on one side you're focusing on LDL, and that's statin. And, then you've got ezetimibe you can add, and if you need to, you can go down further there. But also keep in mind this issue of triglycerides. And when you see that that individual after treatment has that high triglyceride, now because statin, sometimes a high intensity statin, and you mentioned also the importance of diet and exercise, critically important for triglycerides. So alcohol, exercise, diet, weight loss, that's something that if you can get someone to do that and put them in a high intensity statin, you may have taken care of the issue, but frequently we know it's not that easy to change lifestyle. And it's a struggle. So when you see that that triglyceride is persistently elevated, so now you can think on this other thought. They said, okay, what else can I do about that residual risk? And that's where the icosapent ethyl. Now that is, it only mentions that because, as we discussed, the other omega-3s, including the supplements or the other prescription mixtures, have not shown benefit. The fibrates have not shown benefit. Niacin didn't show benefit. So, and even there was a new trial with pemafibrate, didn't show benefit, just came out. So it has been, it doesn't mean there are other things that are in the pipeline. Maybe they will work. They have different mechanisms of action. But for the current time, it's the only thing in that pathway, on that limb of the triglycerides, just like the ADA. And this is the same thing for the new chronic CAD. It's talking about, you got your LDL focus, keep an eye out for that triglyceride, because that might need some extra attention.
Fantastic. Well, we're coming to the end of our podcast. Any last thoughts you'd like to share with our listeners?
I just think it's important. Cardiovascular disease remains the number one cause of disability, pain, suffering, death in the country. There's so much we can do for it. Cancer, those two, but prevention of cancer is, other than smoking cessation, we don't know as much about how to prevent it as we do for cardiovascular disease. So you mentioned a comprehensive approach. Yes, LDL, statins, but don't forget triglycerides, and also blood pressure, diabetes, the weight loss. It's a challenging job when you're primary care, but you're going to impact so many people's lives in a beneficial way if you can comprehensively address this.
Fantastic. What an important message, Dr. Christie Ballantyne. Thank you so much for joining us.
Thank you.
And to our listeners, thank you for joining us on this first of a two-part series on residual risk in vascular disease with a focus on triglycerides, sponsored by Amarin. We look forward to you joining us for the second part of the series, where we'll be discussing some common clinical cases and real-world challenges, maybe even some solutions, to help with addressing residual cardiovascular risk for the American Diabetes Association. I'm Dr. Neil Skolnik. Till next time, stay safe and keep learning.